Welcome to our live session, the session number 169. And we are live on CMAAO platform. Today we are talking about prevention strategies for recurrent UTI. What can be done by her, him, or us? We are meeting on 10th of February. If somebody wants to join this session, can join on 818-8591-1572. Today we have Dr. Pankaj Maheswari. He is pioneer in the use of holmium laser in India, trained in holmium laser prostatectomy with Dr. Peter Grill, New Zealand, established holmium laser in 1998, 70 publications in national and international journal with RG score of 31.42, 56 in index journal, co-editor for Atlas of Embryology and author of 6 chapters in different urology books. Recipient of Society International Urology Traveled Fellowship in 1999. Sir, over to you.
Thank you so much, sir. I'm indeed honored to be part of this excellent gathering. I hope my slides are visible.
Absolutely perfect, sir.
Yeah. So, I have been following Dr. K.K. Agrawal for a long time. I was on his mailing list and I would always get his tidbits and notes, and it would be a pleasure reading them. It was sad we lost sir a few years back in COVID. But when your team asked me to join, I was very happy to be part of this team. Now, you would agree with me that UTI is a common problem. Why do we need to discuss this topic? You see, in time to come, I have a feeling that we will be able to control malignancy because a huge amount of work is happening in genetics, medical oncology, and surgery, but infections would remain the biggest killer. There are no new antibiotics on the horizon, and what we are using is more often a combination of old antibiotics or trying to see what best works for our patients. It is sad that there is a rampant misuse of antibiotics, and hence that is increasing the resistance to these antibiotics. Couple of years back, I had the opportunity to do an antibiotic stewardship course from European Association of Urology. It was a huge learning experience. Over a period of around 6 hours, there were around 10 talks on various aspects of infection control. Though I enjoyed learning in this course, but my head was really down with a form of shame. The reason being, every talk started with such type of map. I would ask all of you to go to Google and say, Google, show me the world map of, say, maximum urinary infections. And when you see this world map, India would be labeled in one of the darkest colors. Now keep on changing the question: maximum TB, maximum India TB, maximum HIV, maximum resistance, or even for that matter, maximum antibiotic use, and the chart will not change much. So definitely we need to do something very, very seriously and aggressively in this matter. Further, the lay public have also started noticing this. This was a recent article in Hindu. When, if you look at this article in details, you will see that nearly 75% of our prescriptions have antibiotics, and around 40% have more than 2 antibiotics. Not only this, most of the antibiotics are given for preventive measures. So we are using it to prevent infection rather than treat infection. And these are all high-end antibiotics, which are called as watch antibiotics. 4 days later, Hindu, and these are the groups of antibiotics which we commonly use. And if you look at this list, where there are cephalosporin, aminoglycosides, penicillins, fluoroquinolones, all of us are at some place, negligent and responsible for misuse and overuse of these antibiotics. 4 days later, Hindu carried one more article to see where the watch group of antibiotics were maximally used. And if you look at this chart, India tops that. We would surely want to top the list probably of the Olympic medals, and definitely not this list. But sadly, this is what the present situation is, that we are the maximum users of most antibiotics in the world. Now look at this chart. Though the picture quality is not very good, but if I can just mark it for you, this is the resistance pattern for various antibiotics and bacteria in India, which goes from 50% to nearly 90%. Now compare this to few of the Western countries or including Japan, the resistance pattern goes from zero point 0.2 to maximum 5%. So the antibiotics which are really useful in the West are no longer useful in our country. What do we need to do? We need to really rationalize the use of antibiotics. That's the only way out for us. Though this may sound to be a very, very uphill task, but unless we understand the disease, we will not be able to take proper steps in this direction. And today I would try to explain to you about a very common problem, which is urinary tract infection, especially recurrent urinary tract infection. Most women, more than half of the women, will have some form of infection in their lifetime. Around 10% men will also experience UTI. So simple urinary infection is one of the commonest reasons a patient approaches us in our OPD. No wonder in US, the cost of this treatment crosses 2.5 billion. Recurrent UTI can be complicated or uncomplicated. You see, a single episode of infection or even two episodes of infection in a year for a lady can be called as uncomplicated. But more frequent infections, infections in men, or infections associated with other anatomical abnormalities or diseases or immunocompromised state are all called as complicated UTI. It is important to differentiate these because the treatment of uncomplicated and complicated UTI is likely to be different. Most infections recur, and one of the most important reason for development or risk factor for development UTI is a prior history of UTI. The infections that recur could be either persistent infection or a new infection. Persistent infection means the same bacterial strain comes back in a short period of time, probably because it was not treated adequately or patient did not follow your instructions properly. Novel infection would be a same or different organism that happens after a longer period or after documented clearance of the infection. Reinfection is more often because of fecal flora, and urinary tract is very, very commonly affected by bacteria from fecal flora. How does it happen? So in women, we know that the urethra is very short. Because the urethra is short, ascending infections are very common and easily possible. Add to that the anatomical proximity of the vaginal passage to the urethra and the higher risk of infections in the vaginal passage. These infections have a propensity to reach the urethral meatus and probably increase the risk of urinary infection. A further compounding factor is fecal passage, which is just behind. And if there is infection from the fecal passage can cause infections both in vaginal passage as well as urinary passage. Once the bacteria gain access to the urinary system, they tend to go up the urinary passage. Once they are in the bladder, they find a very conducive environment where they can grow, multiply, and cause symptomatic trouble to the lady. So what happens exactly? There is intradental colonization. There could be reasons for frequent opportunities for urethral entry. And once they are in bladder, probably there may be reasons why the infection stays in bladder. Not every lady would develop infection. There could be few predisposing factors like genetic predisposition, poor nutrition, or associated comorbidities which make them more prone to infection. Now let's look at each in details. Retarded elimination would happen because of excessive holding of urine. This is one thing which probably I tell in my OPD at least 10 times a day to most women who come with infection. Women have a bad habit of trying to hold urine. There is a very big myth among women that an unclean restroom would cause infection. We need to stress to them that it is not the unclean restroom, but the act of trying to hold urine which causes infection and not unclean restroom. They may have associated bladder outlet obstruction because of which the infection from the bladder does not go out. Poor sexual hygiene and multiple sex partners could be one reason for frequent opportunities for urethral entry. And again, intradental colonization again happens because of poor hygiene and multiple sex partners. So these are the common reasons why recurrent UTI happens. Sexual activity is the most important reason, and we would discuss this in details in future. Family history would be genetics, recent antibiotic use, which is very, very rampant. Menopause, a lady becomes more prone to infections during menopause because of the hormonal changes in the vagina, or if there are any anatomical reasons like, say, elevated PVR or cystocele, they would also make her more prone to UTI. Do all factors play a role in every patient? No. In a young girl, the reason for intrauterine colonization could usually be constipation. Enhanced sensory could be because of masturbation. Again, retarded elimination is because of faulty voiding habits. And again, girls are in a habit of trying to hold urine from very, very young age. In a young sexually active lady, vaginal infection because of repeated sexual activity and postcoital poor hygiene are reasons why the infection increases. They may have associated diabetes or urethral obstruction. In an older postmenopausal lady, again, hormonal withdrawal leads to increased colonization. They may need catheterization for some reasons that increases the risk of entry into the bladder. They may have associated urethral stenosis, which could be related to menopause or which could be related to prior surgeries, or aging and diabetes definitely reduces their differences. So in every age group, the reason for infections are likely to be different. So what can the patient do for this? They can reduce the urethral entry, they can increase the clearance, they can increase the resistance, they can reduce the intrauterine colonization, or they can use chemoprophylaxis. Let's look at each one in detail. So how to reduce intrauterine colonization? The most important way would be to improve perineal hygiene. Perineal hygiene is important post bowel evacuation. Recently, just a week back, I had a young, recently married dentist who was having repeated urinary infections post marriage. Now, if the whenever infections happens post marriage, the first thing that is thought of is probably this is an extension of honeymoon cystitis or recurrent infections related to sexual activity. She kept on getting repeated infections. She was even put on post-coital antibiotic prophylaxis. When I looked at her history in detail, she told me that every doctor tells me the infections related to sexual activity, but because of these repeated infections, I have been off sexual activity for more than 6 months and the infections are still on. So went further into details to find out that once she shifted to her husband's house, the commode at the husband's house had a fixed faucet which was posterior, which was there behind her. So for cleaning post motions, she was using a water jet from a fixed faucet, and that led to the fecal flora coming to the vaginal area. So this is one very important reason for repeated infections. And to tell a lady that post motions cleaning, the water should go from front to back and not back to front. So a hand faucet which is held from the front so that water moves away from the vaginal area. Very important. Post-coital cleaning. Now, a lot of women are in the habit, and these days we see a lot of advertisements on television about vaginal sprays and disinfectants. These should be strongly dissuaded. One, they do not work. Two, there is a potential to cause chemical vaginitis because of this, making the mucosa more prone to infection. Sexual hygiene and understanding sexual hygiene is very important. You see, especially in India, culturally, girls are taught that sex is bad. No wonder post marriage, they get into this habit where they try to clean themselves post sexual activity. They would either use the water jet or tissues to clean themselves. Now, remember that this act of cleaning increases the risk of infection. What do they need to do? Strictly no douching water tubs or any tight undergarments or trying to clean with tissues. What needs to be done is just a post-coital voiding. So I tell them, no cleaning after sexual activity, just pass urine. If possible, pass urine before as well as, but definitely after sexual activity, change undergarments. Our body has a system of self-cleaning by which no excessive cleaning is needed. How does a person reduce the urethral entry? Clean sexual practice is very important. Here, there will be role for the sex partner. as unless the couple is attempting pregnancy, it is important to encourage them to use a condom. Again, if no condom is being used, proper penile cleaning before intercourse is very important. In Indian population, where a major chunk of population is non-circumscribed, retracting the foreskin and cleaning inside the foreskin before the sexual activity should be encouraged so that infection doesn't go from partner A to partner B. Sterile instrumentation again is very important. I have seen in many hospitals urethral catheter, especially in ladies, being done by untrained staff or by partially trained nursing staff. Uh, there is no harm in a nursing staff putting in a catheter, but proper training to them as to how to put this catheter and all sterile precautions would be very, very vital. How do we enhance bacterial clearance? Increase water intake. So a lady has more water, passes urine more frequently, doesn't hold urine in the bladder. So bacteria do not get time to multiply in bladder and keep on getting evacuated. So not only you have more water, you also have frequent voiding. A few things like some fruits would be helpful, especially cranberry, would be helpful in preventing bacterial attachment. We will discuss this in future slides. Now, remember while giving advice of increasing liquid intake, these days, WhatsApp University is something which is extremely dangerous. I get extremes of patients who hardly drink water, or patients who would end up drinking 8 to 10 liters of liquid every day and really spoiling their quality of life. So when you say increase liquid intake, specify to the patient that I want you to have around 2.5 liters of liquid every day, or whatever figure you feel appropriate based on your environmental situations. How to boost resistance? Uh, if there is associated diabetes or any immunocompromised status, treat that well. Improve our nutrition. Overall improvement in, say, giving multivitamins, giving supplements, giving vitamin D supplements, overall nutritional support, regular exercise, all will help boost resistance. One more thing that needs to be stressed here: smoking is on a rise, and smoking in women is also on a rise. Smoking, regular smoking, will reduce the overall immune response to bacterial growth and increase the risk of infection. So this could be an opportunity to stress to them to stop smoking as far as possible. So this was what a patient could do. Now, as a urologist or as a treating physician, what can we do? First and foremost, we need to really be sure that when a lady presents to you with dysuria, increased frequency, this is nothing but UTI. Now, remember, there are few reasons for this presentation other than UTI. A lower aortic, small lower aortic stone can present with increased frequency and burning in urine. So, and also a lower aortic stone would also cause pyuria. So just because a young lady has pyuria with say dysuria and increased frequency, don't label her UTI and start treatment. Look at blood cells. In a straightforward, uncomplicated UTI, you do not expect excessive blood cells in urine. If there are blood cells, suspect that maybe there is some other cause, maybe there is stone. Always ask history whether there is history of previous stone disease. If that is there, maybe a small UV junction stone is really the cause of our trouble and not urinary infection. Recently, I had a mother of a physician who started getting recurrent dysuria and painful void. The lady was treated with antibiotics for nearly a year before they really started evaluating her. Because obviously, mother of a physician, she was postmenopausal. He considered her to be a postmenopausal UTI and kept on giving her intermittent antibiotics, cranberry, vaginal estrogen cream. So treatment was right, but she was not evaluated properly. She turned out to have a small bladder tumor. So even small bladder tumors can present with such presentation. So every person who comes with dysuria and increased frequency, UTI is not the only diagnosis. There can be many things other than this. One important thing that I want to stress is think before advising urine culture. Do not advise urine culture as a routine. Urine culture is not a routine. Before advising urine culture, you need to first decide how this urine culture is going to help in your treatment. Now, irrelevantly done urine culture test would give you irrelevant results and would lead to absolutely irrelevant treatment. Further, you would be surprised that most often urine cultures are not properly done. Again, this is one important message I want to give through you. And if this one message can go across, the session for today would be considered as highly successful. Around 4 to 5 years back, we did a study at Fortis Hospital, Mulund, where any patient who came with a urine culture done outside our hospital was asked simple questions. What instructions were given to you before the culture sample was given? If you keep criteria of, say, midstream urine, clean catch, and fresh sample, that means sample getting analyzed within 2 hours of patient's void, 92% cultures were poorly done. Out of around 80 patients, very few, 6 or 7, had instructions, and none of the women had instructions about how to collect sample. Rather, collecting sample is most difficult in women. You will see there is an increasing trend of labs sending people at home to collect sample. There is a myth among patients that for urine culture, you need early morning sample. So the lady would get up at 5 a.m., pass urine in the sterile bottle, keep it on the table. The person would come maybe at 9 a.m. to collect that sample. He would move around in the city of Mumbai in the heat and reach the sample reaches the lab maybe after 2, 3 p.m. So the sample has been in bottle in heat for probably around 8 hours. Definitely it will grow some bugs. So whenever the history does not match with positive culture, don't rely on culture report. Ask the patient how she collected the sample. And you would be surprised that 9 out of 10 samples, you can write PQ, poor quality over it, and just neglect the sample. If you write culture, if you advise culture to the patient, it is your responsibility to tell them how this sample needs to be collected. So go to the lab, who themselves do the test. Don't give it in a collection center. Before giving sample, clean the vaginal area well, hold the labia apart, pass 50-60 ml urine, then collect 10 ml in the bottle. Remaining should be discarded. And it should be given in a place where there is facility of in-house culture test, so that culture happens within 2 hours of patient giving the sample. Unless all, even if all precautions are taken in women and especially in obese women, you may find that collecting proper culture sample is extremely difficult. So we rely a lot on culture report, but I'm sorry to say that a lot of these culture reports are not properly done. Again, women have one more common problem, that is cervicitis. Cervicitis would also present with increased frequency and burning. Clinically, how do I differentiate between cervicitis and cystitis? So a cystitis patient will have increased frequency and burning at the time of passing urine, or at least the dysuria increases at the time of passing urine, and in between voids the patient may be comfortable or burning may reduce. In cervicitis, there is a continuous element of burning which does not increase at the time of passing urine. So if you have a lady who gives you a history that there is a persistent burning, no increased frequency of urine, no major increase in the burning at the time of passing urine, or associated with some discharge, vaginal discharge, suspect cervicitis, this may not be urinary infection at all. So our responsibility first and foremost is to confirm that what patient is telling us is really UTI, and what report is telling us is really UTI before we proceed further. A lot of patients may be completely asymptomatic and have bacteriuria. Do I really need to treat them? Premenopausal pregnant women, uh, premenopausal non-pregnant women, I'm sorry about this misspelled, premenopausal non-pregnant women, antibiotics absolutely not necessary if they are asymptomatic. Diabetics, elderly patients, it is possible for urine to show significant pyuria. It is possible to show urine to show significant bacteriuria. Again, antibiotics not needed. Patients with spinal cord injury or patients with urethral catheter, do not treat pyuria or bacteriuria. It is bound to be there. If there is a recent urological procedure, there may be WBCs in urine which last for a period of 1 month to nearly 3 months. So if patient has undergone a TURP or a lady has undergone a PCNL for a staghorn stone, do not do urine routine in this lady because there would be bacteriuria and pyuria. If I want to look for infection in this lady, I need to do a culture and not urine routine report. So these would be a set of patients where definitely if there is lady is asymptomatic and shows bacteria in urine, I am not going to treat them. There are a few things again I want to stress here. Indwelling catheters. Now, whenever a person has a catheter in place, I assure you that 100% laboratories would not know how to collect a sample from a catheter. No, it is very, very common for patients to give sample from their bags or disconnect the catheter and collect the urine sample directly from the catheter or put the catheter head into the sterile culture bottle and then give sample. Obviously, this sample will be poor. If there is a recent urological procedure, definitely don't look at pyuria. So I have now started telling them that we do not call them pus cells. The moment we call them pus cells, patients relate them with infections. It is better that we should call them as WBCs because WBCs can be a part of inflammation, WBCs can be a part of healing response, and WBCs can also be a part of infection, inflammation. So all put together, seeing and not jumping to antibiotics for asymptomatic bacteria is important. Further, a lot of times a urine routine report is never collected in a sterile bottle. So if urine routine is showing bacteria, do not take it seriously unless patient is symptomatic. Now, which asymptomatic patients I would definitely treat? A pregnant lady or a patient in whom I'm planning a surgery. So a lady is due for, say, a bladder tumor removal and urine has significant WBCs or urine has grown bacteria. Though she's asymptomatic for infection, I will definitely treat her. A pregnant lady needs to be treated because recurrent infections during pregnancy can have deleterious effect on the growing baby. How do we start antibiotic in a patient with uncomplicated cystitis? Do not jump up to high-end antibiotics. Start with simpler antibiotics with like nitrofurantoin or Cetran. Cetran has a very good response even today. Nitrofurantoin had good response still a couple of years back. Now around 30% samples have nitrofurantoin resistance. Still, this is a good antibiotic to start if we are not doing culture or if I want to start before the culture report comes. Fosfomycin is a new drug. Again, let's not misuse this drug and use it properly so that this lasts us for a longer time. In a complicated UTI, culture is necessary. Review the prior cultures, review the prior treatment history, see what antibiotic she has already received, see what duration she has received, and then decide what antibiotic you want to give. Again, in this situation, when there is a complicated infection, I may want to give antibiotics for a slightly longer period of time. In men, definitely every infection is a complicated infection. So a urine culture will be important. Evaluating this man for probable cause of infection will be important. Older man, there could be BPH. Phimosis in our situation is very common. Again, say upper tract stones are very common. So if a man comes to you with infection, look for other causes, rule out other causes, and if no cause is found, then treat him with antibiotics. Now, how can we weaken the bacteria? Now, this is a very, very strong invader. It has very many ways by which it tends to lodge. I'm sorry. It tends to stay longer in our system. So it will have fimbria, which helps it to stick to the cells. It will have flagella, which will help it to move, and then it has very strong cell wall and capsule. We can have vaccines, antivirulence factors, or we could increase the defense in the bladder. Let's look at each. Vaccines have been tried for a long time. Multiple various vaccines have come up: OM89, Eurovac, Euromune, or Eurostim. Euromune and Eurosteam are available in India. Euromine is a sublingual spray of inactivated bacteria. Around 7 to 11 bacteria have been used in this. Multiple studies are there which have shown response, but a proper long-term study is needed for these vaccines. The very fact that though vaccines have been there with us for nearly 30 to 40 years, they have not become day-to-day use, shows that probably their effect has something more to be desired. Uh, the bacteria increase their virulence by what is called as crosstalk. So because of crosstalk, there is increase in toxins, increases biofilm, and increase in drug resistance. And this happens through small molecules. If we can inhibit the production of these small molecules, then probably we can reduce the virulence of the bacteria. Defensins and cathelicidins are proteins secreted by bladder. Now these proteins, they surround the bacteria and destroy it. The production of these molecules is dependent on vitamin D. Again, vitamin D is very commonly low in Indian population. So maintaining a good level of vitamin D can go a long way in reducing the risk of recurrent infections. If we look at urothelium in detail, we will see that there is a gag layer and there are these tight junctions called as T junctions. In infection, there may be scarcity of gag layer or opening up of T junctions. Can we strengthen this? Definitely. Intravesical heparin or vaginal estrogen will help in improving the gag layer and in restoring the lost gag layer. Are there any drugs to strengthen the urothelium? Topical estrogen. Now, any postmenopausal lady who comes to you with recurrent urinary infection, it is very important to start her on vaginal estrogen. Remember that vaginal estrogen has no systemic side effects. It does not increase the risk of any breast or any other malignancy. And really, because it stimulates proliferation of lactobacilli, makes the vaginal pH acidic, it significantly improves the risk of developing recurrent infections. So this would be one mainstay of treatment for a postmenopausal lady coming with recurrent infections. Asfamifene, though not available in India, is an oral estrogen agonist and has been shown to be very good in UTI prevention. It's a novel drug which is being tried, and it could be a very good non-antibiotic option for prevention of infection. Can we give lactobacillus? Again, lactobacillus has been tried both by oral and by intravaginal route. There are few studies which have shown good results, but pooled data and meta-analysis have not shown any convincing benefit because of lactobacillus. So can be given as a supplement to your antibiotic, but otherwise may not help much as far as urinary infection is concerned. Cranberry and cranberry extract came in a very big way. It showed multiple benefits other than reducing infections like cardioprotective, cholesterol, reduces cholesterol, improves digestive health. It can be taken as raw fruit juice or extract. Raw fruit and juice may not be really practical because the content of active element in a raw fruit is very low. So capsule and tablet should be the way to go. Uh, Proanthocyanidin A has been shown to be effective in preventing E. coli infection. Again, limited studies have shown that few studies have shown that it is effective, but meta-analysis have shown with nearly 4,500 patients have shown that it did not significantly reduce the occurrence of recurrent UTI. So again, you cannot recommend cranberry products, but if somebody wants to take, may or may not work, may not help. In contrast, D-mannose has been shown to be effective. 2 grams D-mannose, it has been shown to be superior to placebo and as effective as 50 milligram nitrofurantoin in preventing recurrent UTI. Again, D-mannose and cranberry combinations are commonly available in India, which can be tried in patients with recurrent infection. Canaferon N is a herbal preparation, sadly not available in India yet, but could be a good replacement for antibiotics for recurrent UTI. Vitamin C is commonly used because of its bacteriostatic activity, but how much it really helps is not known. Again, giving low dose vitamin C supplements does not harm. Vitamin D, we must see to it that lady has normal vitamin D levels, and if they are low, should be supplemented. So what are our options? Why should we try and avoid antibiotics? You see, most of these antibiotic infections are self-limiting. They rarely progress to upper tract infection. The risk of pyelonephritis, whether you treat with antibiotics or with supportive care, is same. Also, antibiotics carry a higher risk of side effects. So as far as possible, antibiotics should be a later choice. In mildly symptomatic patients, just NSAIDs to reduce the symptoms may help. Once the symptoms are low, patient's innate immunity will take care of infection. The risk of upper tract infection or pyelonephritis because of NSAIDs is low, and this will help you delay the antibiotic. Antibiotic prophylaxis should be given in a lady who has repeated infections despite all your precautions. So you could teach her to take a single dose of nitrofurantoin or a single dose of Ceptran whenever the infection starts. If the infections can be directly related to sexual activity, then a single dose antibiotic post-coital is important. Long-term suppressive antibiotics, as far as possible, should not be taken. So this is what we can do to help the patient. Now, what can the sexual partner do? Use of condom, use of adequate lubrication, and proper cleaning is something which must be taught to our sexual partner, and he should rigidly follow it. Adequate lubrication could be in the form of adequate foreplay. If that does not give lubrication, external water soluble lubrication can be used. Finally, recurrent UTI is common. Do not rush with antibiotic whenever you see a patient with recurrent UTI. Counseling for risk factors and avoiding these risk factors is important. Try all the non-antimicrobial measures first before you jump to treatment with antibiotics. Thank you. If there are any questions, I'll be happy to answer.
Thank you, Dr. Maheshwari, for your wonderful, insightful information. I would like to open the session for question answers. We have Dr. Chong with us. Dr. Chong.
Hi, Saurabh.
Hi, Dr. Chong is the chair for CMAAO. Dr. Chong, please, over to you. Dr. Chong, you're muted.
Can you hear me now?
Yeah.
Yes, very clearly, sir.
Okay. Thank you, Dr. Pankaj, for your lovely lecture on urinary tract infections. It's quite pertinent to me because I do have some elderly patients that I'm treating with for urine infections, and some of them are hospital-acquired bugs and can be almost impossible to treat except using intravenous antibiotics. So yes, I understand how important your lecture is, and I'm very interested about your prophylactics compounds that you talked about, including D-mannose and even, well, the legendary cranberry juice. So thank you very much for your wonderful lecture, and it's been very, very helpful for me personally. I'd like to open to the floor for any other questions right now.
I'm honored at your good words, Dr. Cham. Thank you so much.
Thank you.
Dr. Anjali, please go.
Yes, Dr. Kuzi.
Thank you so much, Prof. It was really a very nice lecture. I would like to add here that we do see, especially under our elderly patients, a lot of UTIs, and I've got a suspicion that when the old age home doesn't know what to do, they normally go for a urine sample and then sort of putting pressure on us to prescribe medication. So we have also decided if the patient is not clinically sick and only complaining of a burning or something like that, and the old age home then submit to us a urine monster showing leukocytes, we don't treat it anymore. because you are wasting your time, and you're not even convinced that it is a proper urine tract infection. Also, what we have seen with the elderly patients and even the overweight females is that the hygiene are not good. And so everything that's burning, as you have said, is not related to urine tract infection. And just for Dr. Chang, what the cranberry juice actually does, it reduces the burning sensation. So it doesn't really cure, but it burns at least less. So that's why we prescribe that or advise them to take that. Thanks.
I agree with you, ma'am. Means collecting proper sample and really treating the ladies unless they are symptomatic would be extremely important.
Thank you. Dr. Monica, you want to add something?
I want to say thank you for a fantastic presentation. It was very clear. It was very applicable to everybody in this audience. I think we all walked away, and I have to agree that I also appreciated all the over-the-counter and the accessible remedies that are available, and the very practical approach that, not every sample is an infection, and every infection needs an antibiotic. And you really highlight the need for antibiotic stewardship. It is very important. I'm an allergist, and in the role that I play is that the more antibiotics you get, the more likely you will have some symptoms on it get unfortunately labeled as antibiotic allergic. And then when you have a urinary tract infection that is true, that gives you a culture sensitivity report, and you're limited because of a drug allergy, you ended up putting this poor patient into a corner. So how do we prevent that whole train of events from happening is exactly what you said, is making sure that that antibiotic was given for the right reason, that the sample was corrected, obtained correctly. But I think the other issue is that these patients who are coming to us, they're demanding that sample, they're demanding the test, they're demanding the antibiotic. And it's also a delicate balance of how do we meet the needs of our patients who feel uncomfortable, but telling them that we have to teach them ways to prevent them to have those symptoms in the first place too. So thank you very much for your presentation.
Thank you.
Dr. Pankaj, I also noticed one is that actually most of the urine samples that we obtain especially in women, are contaminated by vaginal fluids, despite
Absolutely.
us telling them not to give us the beginning, not to give us the end, to give us the middle, and it must be a big sample. I know on some occasions we've even had to thought about catheterizing the patients to obtain a clean sample. And do you have any other practical, other than what you've told us to minimize this contamination?
No, so what we have started doing is that when I prescribe a urine culture test, I also give them a pictorial description as to how the sample needs to be collected. You see, the practical problem in the labs is that most of the labs are manned by men, and these receptionists or technicians find it very difficult to explain to a lady how to clean and how to collect the sample. So if you give them a picture at the time that this is out, and spend 10 seconds explaining to her what needs to be done, finally you see the culture is being done for our benefit so that we treat them better. So it is our responsibility to give them correct instructions.
Dr. Pankaj, if you don't mind, could you share that diagram with us later on through our
Surely.
WhatsApp?
Surely, I'll do that. I'll do that.
Hello. Hello, sir. This is Dr. Manish.
Yes, Manish.
Can I ask one question? Yeah,
Most welcome.
sir, generally we tell all the females to use the cleaning solutions like V-wash or similar. So is it like recommended from your side? for prophylactic, because they're using public toilet. The holding is very common in cities for working women. They don't like to go to public toilet or even in the office toilet. So as you said, it's a major risk factor for developing UTI. So can we recommend them like V-wash or the solutions similar to use?
So Manish, my comments here are number one, that you need to explain to them that it is not the dirty toilet, but the act of
Right.
holding
Yes, sir.
which will increase the
Yes, sir.
infection. Instead
Definitely.
of using V-wash on herself, I advise her to carry some tissues and disinfectants and disinfect the seat before using that restroom. Okay.
Yes, yes. Even
So
that is
I do
those are
not want
available.
her to use any chemicals on herself, because I
Okay.
firstly feel that they don't work. And second, I also fear that there could be some chemical vaginitis which could increase the risk of infection. Though this is just based on anecdotal reports from patients. Obviously, I have not done
Yes,
any
sir.
study on these products, but I dissuade patients from using them.
Okay, sir. So basic disinfectant of the toilet seat and tissues,
Yes,
that will help.
yes.
Yeah. Okay. Thank you, sir. Thank you.
I can add one point to that. So when you're thinking about the soft tissues and you're adding chemical-based cleaners, you're actually putting the woman at risk for sensitization to contact allergens from the fragrances that are in the soaps and the solutions. If you add that to the use of the fragrance, sanitary pads that they use, powders, anything else, ultimately what happens is that you create an environment where it is very uncomfortable for these women. And if they have a low-grade contact dermatitis, vaginitis because of these chemicals, then that in itself will create additional urinary symptoms that will then feed into that cycle of dysuria, burning, and need for antibiotics. So that's another reason. And the only way that a woman will know if that she's allergic to it is that the symptoms will worsen as she constantly uses the solution. Then she feels that she has urinary tract infection. She'll use the solution more, and she'll get worse. A really simple way to know at home is something known as a repeat open application test. It's not 100% sensitive, but if you take like a coin-sized amount of a fragrant solution and you place it on the inner crease of your elbow for about 15 minutes, wipe it off, do it 3 days in a row. What you're looking for is the development of a rash 7 to 10 days later. It's called a repeat open application test, or ROAT. And therefore you can see if those solutions that you're actually using to disinfect is actually creating another issue. Can be used to see, but I recommend everything fragrance-free. Everything should be not scented. Everything should be extremely, like your plain water is sometimes the best thing that can be
Best,
used.
absolutely.
And none of these solutions should be used. Very uncomfortable for women.
This route is very, very interesting, worth really trying in few patients. Thanks for this suggestion.
Great. Do we have more questions? And Dr. Pankaj, please do share that picture with me. I will share in the WhatsApp group.
Sure, I'll do that.
Thank you, Dr. Pankaj. And it was a very good session that we had. Learned a lot from you and reinforced some of the stuff that we already knew, but we needed to be reminded. And it's always a pleasure attending these sessions when a very good speaker comes up and tells us what we need to do, reminds us. And it's also the Lunar New Year today for us in Singapore. And I wish everybody a happy Lunar New Year.
Thank you, same to you.
Thank you.
So, Dr. Pankaj, we'll close this session. It was a wonderful, insightful session, and we would request you to do a follow-up session once our team will contact you again. I think it would be required. So with this note, I believe it's a Chinese Happy New Year. So wish everyone the same. And with
Happy
this
New
note,
Year.
we'll close the
Happy New
session.
Year from my side. Happy New Year from my
Happy New
side.
Year. Thank you.
Professor
So with
Bukhari.
this note, we'll meet again on an alternate Saturday, which will be 24th. And with this note, we'll close the session. Thank you so much, everyone.
Thank you. Thank you.
Thank you. Thank you. Happy New Year.
Bye.
Thank you. Bye.